Welcome to our exploration of pain and rehabilitation pharmacotherapy, focusing on the roles of dopamine and serotonin. Chronic pain is a complex condition that affects millions, and understanding the science behind its management is crucial for both patients and healthcare providers. In this video, we'll break down how serotonin and dopamine-based medications are used, their effectiveness, and their place in rehabilitation. Let's start by setting the stage for how these neurotransmitters influence pain and recovery. Serotonin is a key neurotransmitter involved in regulating mood, sleep, and importantly, pain perception. Medications that increase serotonin levels in the nervous system can help modulate pain signals, making them less intense. This is why serotonin-based drugs are often considered for chronic pain management. But how do these medications actually work, and which ones are most effective? Let's dive deeper into the types of serotonin-based pharmacotherapy. When it comes to neuropathic pain, the first-line medications are serotonin norepinephrine reuptake inhibitors, or SNRIs, and tricyclic antidepressants, known as TCAs. These drugs work by blocking the reuptake of serotonin and norepinephrine in the brain's descending pain pathways. This action helps dampen pain signals before they reach conscious awareness, providing relief for many patients with chronic pain conditions. Among SNRIs, duloxetine and milnacipran stand out. Duloxetine is FDA approved for diabetic neuropathy, fibromyalgia, and chronic musculoskeletal pain, with strong evidence supporting its use. Milnacipran is also approved for fibromyalgia. Both medications have a number needed to treat NNT of 6.4 for 50% pain relief, meaning about 1 in 6 patients will experience significant benefit. Tricyclic antidepressants such as amitriptyline, nortriptyline, and diazepamine are often used off-label for neuropathic pain. They have the longest track record among antidepressants for pain, and may even be more effective than SNRIs with an NNT of 3.6. However, TCAs come with significant side effects, especially in older adults, including cardiovascular risks and anticholinergic effects. Starting TCAs for pain, dosing typically begins low at 10 to 25 mg nightly and is gradually increased to a target of 75 to 150 mg daily as tolerated. This slow titration helps minimize side effects and allows patients to find the most effective dose with the least discomfort. Careful monitoring is essential, especially in elderly patients, to avoid complications. Selective serotonin reuptake inhibitors, or SSRIs, such as fluoxetine, citalopram, and paroxetine, are widely used for depression but have inconsistent evidence for pain relief. Unlike SNRIs and TCAs, SSRIs target only serotonin and do not affect norepinephrine, which may explain their limited analgesic effects. They are not generally recommended as first-line agents for chronic pain. Duloxetine stands out as the best supported antidepressant for chronic pain. It has moderate to high certainty evidence for effectiveness in fibromyalgia, neuropathic pain, and musculoskeletal pain. Standard dosing of 60 mg daily is as effective as higher doses, making it a convenient and reliable option for many patients. While serotonin-based medications can be effective, they are not without risks. TCAs in particular can cause cardiovascular events, anticholinergic side effects like dry mouth and constipation, and increase the risk of falls in elderly patients. SNRIs may also cause nausea, dry mouth, and dizziness. It's important for patients and providers to weigh these risks against the potential benefit. Dopamine is another neurotransmitter involved in movement, motivation, and reward. Its role in pain is less direct than serotonin, but it can influence pain perception, especially in certain neurological conditions. Dopamine-based medications are not widely used for general pain management, but they have a specific place in treating pain related to Parkinson's disease. The primary indication for dopamine-based pain management is Parkinson's disease-related pain. Optimizing dopaminergic therapy can help alleviate pain symptoms in these patients. However, outside of Parkinson's disease, there is limited evidence supporting the use of dopamine-based medications for pain relief. For most chronic pain conditions, dopamine-based medications are not considered effective. Their use is generally reserved for patients with Parkinson's disease, where pain is a common and challenging symptom. This highlights the importance of tailoring pharmacotherapy to the underlying cause of pain rather than a one-size-fits-all approach. When it comes to rehabilitation, especially after stroke, both dopaminergic and serotonergic medications have been studied for their potential to enhance motor recovery. Unfortunately, the evidence does not support consistent benefit from either class of drugs in improving motor outcomes after stroke. Rehabilitation remains a multidisciplinary effort with physical therapy at its core. Serotonin-based medications have been explored as a way to boost motor recovery after stroke, but results have been inconsistent. While some studies show potential benefits, others do not, and there is no strong consensus to recommend these drugs for routine use in stroke rehabilitation. Similarly, dopamine-based medications have not shown consistent benefit for motor recovery after stroke. While dopamine is crucial for movement and motivation, pharmacological attempts to enhance recovery through dopaminergic drugs have not yielded reliable improvements in motor function. Key takeaway is that dual-action agents, which affect both serotonin and norepinephrine, tend to be more effective for pain than single-action agents like SSRIs. This dual mechanism provides a broader modulation of pain pathways, offering better relief for many patients with chronic pain. Selecting the right medication for pain management involves considering the type of pain, patient comorbidities, and potential side effects. For neuropathic pain, SNRIs and TCAs are preferred, while SSRIs are generally avoided. In Parkinson's disease, dopaminergic therapy is tailored to address both motor and pain symptoms. Ongoing monitoring is essential when using pharmacotherapy for pain. Patients should be regularly assessed for effectiveness, side effects, and any changes in their condition. Adjustments to dosing or switching medications may be necessary to optimize outcomes and minimize risks. While medications play a significant role, non-pharmacological approaches like physical therapy, cognitive behavioral therapy, and lifestyle modifications are also crucial in managing chronic pain and supporting rehabilitation. These strategies can enhance the effectiveness of medications and improve overall quality of life. Summarize, serotonin-based medications like SNRIs and TCAs are the mainstays for chronic pain management, with duloxetine having the strongest evidence. Dopamine-based drugs are primarily used for Parkinson's disease-related pain. Neither class has shown consistent benefit for motor recovery and stroke rehabilitation. A personalized, multidisciplinary approach remains essential for optimal outcomes. As research continues, new therapies may emerge to better target the complex mechanisms of pain and recovery. For now, understanding the strengths and limitations of current pharmacotherapy helps guide effective and safe treatment plans. Always consult with healthcare professionals to determine the best approach for your individual needs.